Oh, no wonder. You can't see me. There I am.
Hey.
Okay. All right, guys. I'm here with Dr. Serafino. Hey, Dr. Serafino.
Hello, Mandy. Dr. LaGreca, how are you?
Thank you. Thank you, guys. So real quick here, you guys got the notification for this really important meeting. I wanted to give you a little background about where I met Dr. Serafino and where he fits into this whole IC healing journey. I actually had a friend of mine who used to be a client who started doing FSM, which is Frequency Specific Microcurrent. Her name is Andrea. I don't know if she's on here listening or not. And she told me she started doing it because she had a lot of like vulvodynia, she had some fibromyalgia, and a lot of chronic pain that she was unable to get full resolution of. So when she worked with me, we made a lot of progress with her on her pain through dietary interventions and, you know, reducing inflammation, but she still had this lingering pain that was coming on and off. So she started doing it and she told me about it. And at first I was just like, oh gosh, I have to learn about another thing. But I went and said, you know, let me explore this a little more. And she helped me find somebody in my area. And so she found Dr. Serafino. And so I went ahead and started to get treated and really got to know him and got to understand what he specializes in. And I realized, wait, how you can really be very, let's say, an interesting approach to the last missing pieces for some people who are having trouble getting rid of like all of their pain. So we're here to talk about this because, you know, I see, as I talk about in my IC Healer course and as I work through with my own patients, IC is basically, it's got many causes, right? So I talk about the 8 root causes in my course, and we talk about, you know, infections and toxins and the need for detox and stress and inflammation and gut imbalances and immune system are many of some of this perfect storm. But what is actually happening is, and I'm learning is when we have chronic infections, chronic inflammation, even chronic stress, it changes how our brain perceives this stress and how our brain responds to the pain and how our pain is actually transmitted to our brain. And, you know, there's some things that, you know, I talk about and I've identified with my clients, and that includes, you know, mold and candida, which are actual very huge triggers of inflammation in the body. And a lot of people, when they run organic acid testing, we see that they have mold, they have candida, they have both mold and candida. And then as a result, downstream from that, they have problems with oxalates, which they produce oxalates in the body. Oxalates are very pro-inflammatory. They activate the inflammasome. And so I believe that there is definitely, for people who have had long time exposure to bacteria and pathogens, and even when they eradicate it, I know we'll talk about this with Dr. Serafino, they actually have this neuropathic pain, I guess they call it, that's lingering from having years of infections. And so I want to talk about that with you today. And so, and I know you know a lot about this. And so before we begin, let's hear more about, you know, who you are, what you do, and, you know, where you found your interest in all this stuff.
Yeah, so my name is Clint Serafino. I am a physical therapist. I currently live in Charlotte, North Carolina. I've been a physical therapist for 7 years now, and I have gone through some advanced training in orthopedic manual physical therapy, which is, I did a fellowship, and I'm a member and a fellow of the Academy, the American Academy of Orthopedic Manual Physical Therapist. So kind of like Dr. LaGreca, Mandy has gone through with her doctoral studies over the last couple of years. That's the fellowship is a kind of a post-doctorate training sequence. So what's cool with that is that I'm exposed to more, or through that, I suppose, I was exposed to more of these nuancy kind of patience, and then how to manage, how to connect on what's actually going wrong, and then how to manage and help treat some of these patients. So historically, my specialization has been, you know, less in some of the like super, you know, cliche things like just your grandmama who broke her hip and you need to walk her down the hallway in the hospital. I don't do a lot of that. In fact, PTs do way more than that. And on the flip side, I haven't done a ton of like specific neurologic cases. So my specialty has been more so patients, similar to Mandy, where they come with, by the way, do they call you Mandy or Dr. LaGreca? Or
either one. Yeah, Dr. Mandy, Dr. LaGreca, Mandy. It's okay, either one.
Perfect. So my specialty has been more of these chronic conditions that many practitioners, providers haven't been successful in figuring out. And so kind of like you said previously, I mean, I tend to look at the body through a different set of lenses. And so oftentimes many patients, not just patients with bladder pain or interstitial cystitis, many types of patients need an alternate perspective to finally get over that hump of, the last few things that gets us from, no change to some change, something meaningful that's different. I want to be very clear. I don't mean to sound like I fix all of these chronic people that no one can get better. That's not the truth at all. In fact, I'm well aware of my limitations. But I think what I do bring to the table is a different vantage point, different perspective than just your typical physical therapist, and just your typical, I'm not a physician, so I don't have the ability to prescribe meds or order images or do surgery. So it's a different lens that I've been able to curate over the last several years. And that's kind of what brought me to where I am today and, here with you, Mandy.
Yeah, and so I might as well make that disclaimer. Please use this as only informational purposes only. This is not meant to be medical advice. Please seek the advice of a healthcare provider if you have a medical condition. I just want to say that because what we're doing here is really just educating you. We're not telling you what to do, and we're not giving you medical advice. So thanks for bringing that up. So, well, thank you for that. And so it's a really interesting perspective, actually, one that I have found to be very, very useful for me to understand my own patient population and understanding their needs. And so not everybody, just to clarify, not everybody's going to fall into this category. I think there's a lot of things at play. I think there's genetics. I think age. I think there's, how long you've had the condition. Because I've had people who've been able to just make dietary changes and their pain's gone. And there's a percentage, I would say maybe about 25% will end up having to go into the next level of further exploring why they have this chronic pain, even when everything else is looking squeaky clean, perfect diet, they're meditating, they're doing all this stuff. I'm like, what's going on here? So let's start down the line. The first thing I said, we know that IC is linked to bacteria. We know this now because we can test these bacteria in urine. We can test it on stool. And even on the organic acid test, we can do mycotoxin tests. And we do find that people with IC have elevations in something pathogenic. And they also have a genetic predisposition. So, and I explain a lot of this in my course, my 8 root causes course. But we also know there's different subtypes of IC. So there's, but bacteria seems to be very common across the board. So let's talk about that. How does bacteria play into this? I know you talked to me about the footprint and the toxins, and I know that I've seen even systemic infections with people like Lyme, chlamydia, herpes, HPV, Epstein-Barr. So, and I know this is a very hot topic of people who are listening right now probably want to know what's going on. And this is the perfect storm. So how does that play into nerves and nerve pain?
So what's interesting about when there is a pathogen or something that's creating some sort of pathology or problem or dysfunction, there are kind of 3 levels of that footprint that we'll kind of talk about. So, the first is with an active infection, what we need to do, whether it's bacteria or whether it's, an active acute exacerbation based off of mold or a mycotoxin or something like that, or chlamydia, there's an immediate acute response where the cells are behaving in a certain way that when you take medication or you take an herbal supplement or you get a treatment of some kind, that we're able to affect that instant kind of change in behavior of the cell. The second layer of that is even when the initial infection or the initial pathogenesis has been removed, the cell may continue, or I guess in the environment there, the environment may continue to have some sort of toxic reaction. So maybe the infection is gone, the virus is gone, but there's still essentially like metabolic waste of sorts. So it's kind of like driving your car, right? Like the fuel is gone, but there's this exhaust that you can kind of smell after the car passes, right? So oftentimes the second layer there is the cell can continue to be influenced by the toxin or some sort of remains. And so then there's a secondary treatment, right? We have to also treat not only the initial infection and what was initially causing it, but now we have to treat these secondary waste products, whether it's a toxin or whether it's a secondary infection or a bacterial overgrowth that has occurred. Candida might be a good experience, or even a SIBO might be good examples of that too. Like the initial infection may have started to clear, but some of that secondary, since those cells were dysfunctional over time, there was an overgrowth of bacteria. That's something that's continuing. It's different than the initial cause, but it's continuing to change the way that the system is functioning. So that's kind of like the second little degree. The third degree is indeed that footprint, let's call it. So sometimes the cells will maintain this memory where the infection's gone, we've cleared away the toxins, but for whatever reason, we're still either tripped in those switches or into that active, whatever the symptomatic position, or maybe secondarily, as those cells begin to reproduce, the DNA in the nucleus actually reproduces cells that are already prepped and ready for that problem. So we're actually replicating and reproducing not the infection and not even really the toxins. It's just the systemic response to this is how we were programmed to reproduce and replicate. So that's what's interesting about the traditional medical model looks at, well, you don't have the infection anymore, or, and even some of the allopathic and naturopathic medicine, we don't have any of the toxins anymore, but for some reason there still is this systemic change that may lead to global or systemic inflammation or otherwise multi-system dysfunction.
Yeah, we see that a lot where people are like, I don't have an infection. I don't know why I'm still in pain. I still feel like I have a UTI. So that's a very, very interesting and non-traditional way to look at that. So, okay. Well, and we'll talk about at the end of that about how FSM can help. So, all right, so let's go into the second part. So I know some people also have structural abnormalities. I have the tailbone that's kind of protruded, and I have that tailbone injury. Tilted pelvis is what I was told. I have the sacral and glute imbalances. So how does that play into this mystery of the pain syndrome?
So that's interesting. When we developed the technology to take an X-ray, take an MRI, take an ultrasound, we all of a sudden could see things that we didn't anticipate, or we could see things that on one person looked different than another person. So we started to understand more about what normal might look like, and then we started to understand what abnormal may look like. And so the tricky thing about this is symptoms never, I had a mentor one time say, symptoms don't come from space, right? Like symptoms come from somewhere. Yeah. It's easy to have symptoms and to look at a test or an image or an ultrasound and go, oh, this is the physical thing that's causing the symptoms. The problem is, particularly speaking to the physical therapy literature, there is extensive literature that would support an X-ray or an MRI finding like arthritis or a disc bulge or a pinched nerve. Those things that we can see on an X-ray or see on an MRI do not closely correlate with the patient's symptom presentation. So when I teach some of this stuff, we talk about a study by a guy named Brinjikji, and he did work with Jarvik. But one of the main studies that we talk about is 3,100 MRIs, and they all show different levels of degeneration and arthritis changes and disc injuries and bulging and protrusion. And the percentages increase with age. But what doesn't happen is in those 3,100 plus MRIs, all of those patients were asymptomatic, no symptoms. So while their picture showed a structural change, a problem, oh, we got to cut that out, or, oh, this is the thing that's causing your pain. These patients did not have any symptoms, no pain, no restricted range of motion, no strength loss, no difficulty completing their activities of daily living, yada, yada, yada. So the difficulty here is using the pictures as a piece of the puzzle, but not the only piece, right? Not defining what we're going to do. So in your case, Mandy, the structural abnormalities that some patients have they present with a varying degree of significance. Not that yours isn't meaningful or that anyone's isn't meaningful, but that may not be the only thing that's contributing to the dysfunction. And interestingly enough, we find the same thing to be true about lab tests, whether it's blood work or whether it's other, other things. Sometimes you see a normal finding in a reference range, right? Oh, this is normal, but this finding compared with this finding, and then this test compared to this test, this group of symptoms actually is a problem, even though this one is normal. So it doesn't just apply to skeletal structure, muscular structure. It can also apply to the inside, our whole system response to dysfunction. Not everything that looks abnormal is dysfunctional and symptomatic, just like not everything that looks normal is healthy and clean. Sometimes that can be dysfunctional and problematic.
Sorry, you hear the toilet going off. That's my daughter over here.
I can't hear it. My neighbor walked by with a weed whacker a minute ago, so.
Oh, I didn't hear that.
Oh, okay.
Good. I'm like, you really got to flush right here. All right, so this is our lockdown situation that we have to deal with. So yeah, that's really interesting. I agree with that, and so I think maybe sometimes we're chasing the wrong things, because I wonder if people who are going to pelvic floor therapy, I've had clients that tell me that pelvic floor flares them up. They go in and get the pelvic floor therapy and they feel worse. So I'm almost wondering if sometimes that's just what they're doing because that's what they think they're finding. And yeah, it's really, really interesting. It's like, could that really be the problem? Is it really pelvic floor dysfunction? Or maybe it really isn't pelvic floor dysfunction. Is there a way to define that?
That's a good question. To a certain degree, it's almost examiner bias or confirmation bias, right? So to give you an example, if you go to an acupuncturist, you expect an acupuncturist to use needles in addition to, herbals and other interventions like that, if they're a traditionally Chinese medical practitioner. Same thing if you go to a chiropractor, you kind of expect them to adjust the neck and the back, right? So there's a certain degree of, I have a hammer, so let's just smack these nails. So some patients, particularly in your population, the population on the IC Healer page here, sometimes when we come into a PT evaluation and it's a pelvic floor evaluation and we go, oh man, these muscles are tight, or this is so loose, or no wonder you can't hold in your urine, or no, we start to treat some of the things that are wrong, but we've identified dysfunction and impairments, and we haven't actually identified correctly the symptom generator. So sometimes for your patients who go through, or your clients who go through traditional pelvic floor, whether it's external, like, okay, here's my verbal instructions, you're going to do this, Kegel here and do this there, or it's internal where there's actually, it's a private room and they're going into either the vagina or the anus to touch some of these muscles. Practitioners can actually undo, help treat some of these muscles that are helping to create some sort of stability in the system. And that can either lead to more pain elsewhere or an increase of your systems. Maybe you're urinating more frequently, or you're incontinent and you can't actually hold in your urine or hold in, fecal matter. So it's a matter of identifying correctly what is the symptom generator, what is the driving cause. Because as we said previously, right, like symptoms don't come from space. That's one of the things that we learned from the FSM practitioners. And then how do I treat not only the impairments that I can measure and touch, but also how do I fix or help address some of the symptoms themselves, or the generating symptoms themselves?
Interesting. Okay. Yeah, so that's great. That's actually interesting and different perspective, because I think there's people who go to pelvic floor therapy constantly and they're either getting worse or they're not getting better. Some people say it helps, but a good percentage of people have said that it hasn't done anything for me. So again, it's not addressing the root cause again.
To be very candid as well, I am classically not a pelvic floor specialist. I've become a generalist, and I'm comfortable and competent in treating a variety of conditions. But one of the first things, Mandy, was like, here are some of the things that I can see, that I can assess. Here's some of the things that I can do for you, but I'm not going to waste your time and your money. If for some reason we get down this road and you're the same or worse, I got to reevaluate what I missed, or I got to figure out how to get you to the right practitioner, because I'm not your guy, right? So I think a lot of times it takes a certain amount of internal reflection on my part and humility on the practitioner part. Like that sounds a little bit like, who's humble? Raise your hand if you're humble, right? Like I don't mean it like that, but
Yeah.
like it takes a bit of like looking in the mirror time to say like, I'm not the right answer, instead of, oh no, I can fix that. You know, just keep coming back. 10 visits, 20 visits, you know, twice a week for 12 months, right? Like you're like, holy cow. At that point, you got to kind of figure out what hasn't been pursued because I'm not getting better or I'm getting worse. Like we got to figure out how to get to the right people after that.
Okay, I know you say you're not pelvic floor specialist, but I just want to just ask this real quick. I just don't understand how somebody can have pelvic floor therapy if they're not like a cyclist and doing tons of exercises. So even if they do have pelvic floor dysfunction, you know, it's not necessarily anatomical in the sense that they did something, exercise, or did overstrained it. Could it just occur as a result of chronic inflammation being present?
So the short answer is yes, it could. I guess to flesh that out a little bit, so our bodies are designed to adapt and survive. So over time, a little change in the system, we adapt to it, right? We move a little differently. You know, our body secretes something, a hormone, or they don't process something correctly, right? They make that little change. Over time, that little change, if you don't address it, kind of like steering a ship, right? If you're 1 degree off, not a problem for the next couple of miles. It's a big problem if you're sailing across the Atlantic, if you're 1 degree off from your destination. It's a long distance.
I like that. Yeah.
So the chronic inflammation doesn't just start, right? So over time, as the body starts to make these adaptations here and there, and maybe there's a structural thing, maybe there's a little injury, but we push through. Maybe there's one UTI that mostly cleared, and for some reason, like the compounding nature of our bodies leads to this point of where it's like, okay, multiple things are going wrong. We have chronic inflammation. Our body doesn't tolerate stress well. I'm not able to digest and absorb these nutrients like I should. And then usually it's when we get to that spot or that point of like, I got to find the right help. I got to find the right person. At that point, there are so many layers to peel away. That's what really leads to a complex chronic situation. And most of the time, if we're honest with ourselves, we can kind of recognize, yes, this didn't start overnight. I recognize that it's going to take Mandy several visits, or Clint, several visits with Mandy, several visits with Clint to see a meaningful change. It won't be an instant, magic wand where we can just reset everything. A lot of times the practitioners position themselves and they say like, oh, I can fix that, no problem. And then, 1 or 2 times comes around and you're not really that much different, or you're only a little bit better. We don't think about how long you've been in that chronic position, that chronic condition first. If you've been chronic and dysfunctional for years, years, it's not going to take 2 visits.
Thank you.
To get you better.
Did you guys hear that? Because that's really important. I just want
tell me to say that.
Well, it's really important because people sign up for 6 months, and am I going to be healed in 6 months? You had IC for 10 years. Right. I don't want to I'm very transparent. I tell people, I don't think so.
Yeah.
But
kind of like the
40%, 50% better at that point. How would your life look if you're 50% better and you're on the road? And I'll tell you what, Clint, I can call you Clint, Dr. Serafino, we're all friends here. Honestly, I have had IC for 10 years and I'm on year 4 of healing. Okay. So 3 years, this is number 4. And I am probably about 99.9% there, and I even say, maybe I won't get to 100. Maybe I won't get to 100. Maybe I will. Maybe I won't. Maybe I will. I don't know, but I'm way happier at 99.9 than I was at where I was when I started. So yeah.
Think about it from 2 perspectives. The first perspective is kind of like New Year's resolution status, right? I'm going to get into the gym. I'm going to run 3 times a week. I'll do resistance training. I'll do yoga and meditation, once a week or twice a week, right? I'll do sauna every other week. To go from nothing to New Year's resolution status, It's a hard change to make. That's why nobody makes it past February,
Yeah,
right?
I see it in the gym.
Yeah. So it's the same thing. It's that expectation. If you were working out and then you stopped working out, uh, is there a certain kind of maintenance dose we can get you on where, okay, I know that if I work out 3 days a week, my back pain stays away, my knee pain stays away, my weight I can maintain, I can eat what I want, drink what I want, but I know my weight and overall health maintains. It's the same thing that the psychologists talk about when they talk about managing major depressive disorders, right? So if you look up research as far as treatment for major depressive disorder, right, you will find counseling, you'll find group therapy, you'll find all sorts of pharmaceuticals and spiritual wellness, meditation, yoga, you'll find all the stuff. But what you will always find is, I shouldn't say always, but I mean, Justin Bieber told us never say never, right? So like, I shouldn't say always. Usually what you find in the literature is the term symptom management or some sort of manage. And I think that's kind of what you're describing is like, you're 99.9% better. You've done a lot of stuff to get to this point, and now you can manage those symptoms, those flare-ups with, you know, some of the nutrition changes, some of the water fasting, some of the ozone, FSM. You have the ability to manage on your own, so you can kind of keep this lifestyle, which is the same thing we do from a fitness perspective for the most part, and we do that in the psychology world for managing patients with major depressive disorder, because they may never get cured and never have a depressive event again, but they have these coping strategies, they have these tools to manage it. And that's the biggest thing, is life is about managing these pieces, not like all of a sudden waving the magic wand and ta-da.
I say that all the time. I said, I'm not a magician.
Yeah.
You know, I wish I was, but you know, the one thing is, I learned in immunology is that you have memory T cells. And so in case of autoimmunity, which is another very common comorbidity with IC, and I do believe IC is a form of autoimmunity. Although it's not listed as in the literature as autoimmune, but it presents itself because they have other autoimmune conditions. Most people have some kind of thyroid. They may have lupus, or they may have Crohn's disease. The memory T cells is what makes this incurable, because, you know, those will always be in your body. You can't get rid of them. And so we're just trying to shut them off epigenetically. It's an epigenetic, you know, shut off. You know, we're trying to shut down the presentation, and that goes through lifestyle, which is like 70% is lifestyle and 30% is genetic. So, you know, we may have the genetic predisposition, which is why I run genetic tests on all my patients. I try, if they're willing to do it. That's the other half of the battle. Are they willing to make that investment? But when we do, we identify, oh, look at this. You have pro-inflammatory gene SNPs, and you have, you know, methylation gene SNPs, and you've got Compton, you've got, you know, vitamin D stuff. And it's very eye-opening, because it shows you, okay, that's that 30% piece. So now you know you have this tendency for IL-6 secretion. So what can we do to avoid that and prevent that? Well, that stress is number one for IL-6, and there's infections, and, you know, being exposed. If you're living in a moldy house, that's right there. And so let's lead to the next question. So let's talk about that, because I just did a remarkable training with Great Plains. And I already kind of knew about mold, but I didn't know how huge the mold connection was, and with mast cell activation. And so IC is absolutely associated with mast cell activation. It is in literature. You can read the urology journals. You can Google it. It's there. Doctors don't always explain it to their patients about it, but I know that's the presentation of IC is mast cell activation. They can measure it in the urine. And people who have Henner's lesions, which is the type of IC that presents itself as with ulcerations, have about 6-fold increase in mast cells. And those who are non-ulcerative, like myself, and 90% of IC people are non-ulcerative, it's a 2-fold increase in mast cells. And we also tend to have histamine intolerance and can't tolerate histamines in our diet. And so we find that the mast cell activation is very strongly correlated to fungus and to candida presentations in the gut, and also colonizing the body, whether you're inhaling the spores or you're eating it from your food, because you can get fungus from things like pistachios and peanuts and apple juice and moldy apples and wheat, and also corn. So that's the number one source of mold in this country, is actually from corn consumption, corn. Okay. So I'm curious because, and just, I see when people have mold, they also have elevated levels of quinolinic acid, which is a byproduct of tryptophan metabolism, with tryptophan shunts through and produces quinolinic acid as a result of stressors, which can be inflammatory and infectious driven. And that's very inflammatory, quinolinic acid. And it's actually a neurotoxic. You don't want to have that. It's a functional marker of neuroinflammation. It's an NMDA receptor agonist, and it released by your activated glial cells. So how can that, knowing this, so if someone has mold and they have candida and they have elevated quinolinic acid, how does that fit in with this neuropathic pain that you're seeing with people that you work with?
So that's a ton of information, and candidly, a lot of that information is your specialty, not mine. So the best answer I can give is the nervous system, your brain remembers things. It's those memory T cells in part. There's a lot of other pieces of the puzzle. Those types of either fungal triggers, toxin triggers, mold triggers, when they start, again, like we talked about previously, there can be this chronic addition, chronic accumulation over time. So perhaps at a lower level, your body is able to, metabolize and excrete appropriately. The liver works well, fecal system works well, and you can get it all, metabolized out. In excess, the system stays ramped up into that. I got to fight this off. So neuropathic pain, there are, just like the IL-6 markers you were talking about, epigenetically, we can kind of test that. We can see that when we start to have dysfunction of those neurotransmitters, things like interleukin factors, cytokines, substance P, glutamate, all these different fancy neurotransmitters.
Right.
The body and the brain.
You can measure in urine, by the way.
Yes. Yeah. The body and the brain tend to keep the system primed and ready, so that now the littlest trigger starts to kick that system into action to then either create pain, create infection, create whatever the symptoms are. So a good example of this is like almost like a patient maybe with a fibromyalgia presentation where they just have this chronic widespread pain. For me to put my hands on them, as a physical therapist, maybe I just need to like mobilize their shoulder, or maybe I'm just assessing, how's their shoulder or how do their legs move? Sometimes just the touch of my hand kicks up that pain response, and they're like, wow. That hurts so bad. And did I create pain with my hand? Like, they responded with a pain response to a non-noxious stimulus. That's called allodynia. But that's the beginning of that's an example of a neuropathic pain kind of presentation. So for a patient with interstitial cystitis that has some of this predisposition for either a fungal overgrowth, a mold toxin, or otherwise, the system's already standing ready to be sure we can fight whatever the next piece of the puzzle is, whatever the next symptom is. So then we get carryover things like vulvodynia or pain with urination, pain with intercourse, even abdominal pain. One of the things that we found with you was like the compensation of that right side, right? Like it wasn't necessarily symptomatic until I poked and touched on it, and it was a little bit of this like withdrawal, like, ugh, I didn't really think that was even sore. But the body tends to go, hey, yeah, I'm already angry. This already sucks. So don't do that. That hurts. And the trigger, the difference between nothing and pain is such a smaller stimulus that's required.
Neuroplasticity, is that negative neuroplasticity? Is that what we're talking about here? Or is there some kind of plasticity going on with the pain, desensitization, I guess? And
yeah, so neuroplasticity happens two ways, right? You can either adapt positively or adapt negatively, and that's a much longer conversation. But yes, those neuroplastic kind of changes where the body and the brain have certain memories, and it's not so much a memory as much as it's a consistent firing pattern, so to speak, that ends up becoming virtually hardwired. That's what ends up, we call it neuroplasticity, and that's the piece that starts to instantly cascade into pain when you have this symptom, or during a flare-up. It takes such a little stimulus to cause a flare-up. Like, give me an example, or from your life, right? Like, you know that even some small stress, whether it's pre-COVID, right, and it's just, you know, an interaction with your child or just something benign at work that ends up causing this sympathetic response, your body goes into, oh no, and kicks you into pre-symptomatic. That's a neuroplastic, habituated kind of pathway that we know that delicate system has just a hair trigger to turn on your symptom response.
Interesting. Yeah. That's where the management comes into play, because if we know that, you know, we have to have modalities. And that's why I really want my patients to make sure that they are exercising. So that's like exercise, meditation are highly underappreciated. And I think sometimes people think, oh, I'm not overweight, why do I need to exercise? I'm like, it's not because of weight. I've done papers in school about the role exercise has on microglia activation and what it does for actually just the brain in general, and how the neurochemicals, like, so going back to quinolinic acid, right? That quinolinic acid is preventing you from producing adequate serotonin. Because if tryptophan is being shunted into quinolinic acid, you're not going to have enough to go into the serotonin pathway. Well, serotonin is your happy, good feel mood hormone, right? That's why people take the antidepressant medications to boost their levels of that. Or, you know, I guess I don't know how they work, but that's what they do. They increase your levels that are available in your brain. But that's what exercise does. So does exercise help with neuropathic pain?
So it depends, which is always the most enraging answer, right? But if you have these pain symptoms and you have this dysfunction, it's probably not the best idea just to go do 4 spin classes a week and start to do, you know, burn boot camp. And well, you can't do burn boot camp now anyway, but the point would be to just jump into some exercise may not be appropriate until we get some of the symptoms under control. But in addition to what you're already doing for treatment and for management, the addition of exercise, I'll talk to you about the NEAT principle if you're not familiar with that, and even things like even things like meditation. Those can help to manage some of these just the system response, which is a beautiful thing to not neglect.
Yeah, I think it's important. I mean, I think do within your ability, but you know, like even like the hit, you know, high intensity interval training, even done in short bursts, can actually change brain chemistry just because of some of the chemicals that are being secreted. You know, like the endorphins and the catecholamines and you know, serotonin and all those other things. So I want to make sure I covered everything that I want to talk about with that, because. So you have somebody, and so we've done the nutrition, we've done the inflammation protocol, anti-inflammatory diet, we've done the gut protocol. They've gotten their gut back to balance somewhat. It's hard because the gut is linked to the brain. There's a gut-brain axis. So if they're stressed, you're still going to affect your microbes. That's a whole nother topic. And then they've done the exercise, they're meditating, and they're still not where they need to be. They're still, let's say 80. I have a couple of patients that are like 80% there. I'm just not 100% yet. And we're absolutely certain you've done all the detoxification protocols. You've done the binders. We've gotten get the mercury out of your body. We've gotten the mold out of your body. You've removed yourself from the trigger, the moldy home. So this is where I think FSM is really important. So another thing I did also want to mention is stress too. Before we get into FSM, can you just explain also the stress response to their pain? Because I read a really interesting article. It was very scientific, so I didn't want to share it to people, about stress and pain, and you know, what is it doing to you when you're under chronic stress and your stress is just off the handle, and then lead that into FSM after you're done talking about it.
So I'm in the middle of a book called Why Zebras Don't Get Ulcers. It's by, I think it's Sapolsky, Robert Sapolsky is his name. So there's a ton of just systemic responses to pain that he goes through. It's a really great book. I recommend it. We know a couple of things. We know that with sympathetic activation, which means in your body, you have autonomic nervous system, you have sympathetic versus parasympathetic. The sympathetic nervous system is your fight, flight, or freeze, right? And the parasympathetic is rest and digest. So when we are acutely in our sympathetic state, we do things like lift cars off of babies or humans, right? We run from predators. If we were, you know, in the wild, we were being chased by a bear, we would be able to run. If we twisted our ankle, or if we smacked our arm on something or cut ourselves open, like, we would still be able to inhibit and shut off that pain response and run to safety. And then only after we're safe and after we're, you know, we're the adrenaline rush is gone, then we're like, oh my goodness, I smashed my arm up, or oh man, my ankle hurts so bad. We start to feel that pain afterward. That's what happens in the sympathetic nervous system acutely. Chronic exposure to sympathetic activation, we call it adrenal fatigue, right? But it's not just adrenal fatigue. Let me be very clear. But like that chronic exposure to the low to moderate level stress, which is kind of like where we operate as humans these days, right? There's stress at work with our bosses. There are deadlines at work. There's traffic on the way to work. There's budget when I get home. There are kids schedules to keep up with. Oh my goodness, my kid is sick. Now that changes everything. Oh my goodness, now COVID. Now I can't go. Like all those things, those add up to the chronic sympathetic nervous system. And chronic sympathetic activation over time changes immune function. It actually exacerbates pain for a number of reasons, which is not really important now as far as mechanisms. But over time, we will last much, much longer in our sympathetic tone, but we don't get the nice, cool benefits of pain inhibition at that point. We actually get pain exacerbation, because your body has to figure out like, okay, I'm having trouble digesting. I'm having trouble, you know, sleeping. You know, there's all these pieces to the recovery puzzle that I'm not getting to. So maybe I need to ramp up this pain response so that I can get your attention. Like, hello, like, is this thing on? Like, you need to slow down and settle down and take care of yourself. So there's a certain sympathetic, parasympathetic balance that has to be maintained. And even though sometimes when you're in sympathetic, you inhibit pain, most of the time where we are with this chronic pain feature is a disinhibition, where the pain starts to creep back up. And now it can look like joint pain, you know, knees and hips and backs. It can look like neuropathic pain, like zingy, tingly down the leg, down the arm. It can manifest a whole number of ways. If I can use you as an example again, like you have seen this happen both sides, right? Where you come in to see me and you're like, it's a rough day. I'm sorry, I'm late. This happened. You know, I'm not gonna lie to you. I'm really kind of flared up. And we treat and we do what we're gonna do. And then it's like, wow, there's this instant change. And then once you appreciate the move from essentially sympathetic to parasympathetic, where we've kind of down regulated your system, then over time, you've actually texted me and gone, I need to come see you. I'm feeling a flare up. This is no good. I mean, this is going on. This is going on here. And then we make an appointment, and then it's like, you know what, a couple of days later, I'm actually pretty good. I ended up, you know, these things kind of squared away. I didn't have this stressor in my life anymore, or I ended up doing this thing that, you know, and I got a workout in, and actually was something I needed to do, and I actually feel better. That's that whole education to the patient. Here's what we expect. Here's your, you know, exercise management, maybe some nutrition management, maybe some meditation management, and cool. This flare up at first makes you go, oh my goodness. But now over time, we can recognize that I'm going to push this back to parasympathetic and actually take a deep breath and allow my system to reset.
Yeah, there's some kind of plasticity happening with me as well, where I noticed that I for having IC for 10 years, I always have this expectation of a flare. And then, so I think sometimes because I expect it, and then I feel like, oh my gosh, I just I just yelled at my kids, and I'm going to be in a flare. And then I end up waiting, and I'm like, oh, it didn't actually happen.
Yeah.
You know, and part of me thinks that maybe that's also because of FSM, because I think what I'm doing with FSM is, even if I start having the beginning symptoms of one, it's kind of like, oh, never mind.
Well, so that again happens both directions, right? So in Sapolsky's book, what he talks about is no longer are our threats running from bears and predators in the wild. Now our threats are work and culture related, and they're also expectation based in our brain. So we can have the same sympathetic upregulation even with the thought of something that's anxiety provoking. And so, like you said, even though
heartbeat going really fast is my telltale one, when I start feeling, and sometimes I'll get anxiety from nothing. Just my brain worrying about, oh my God, the bill and this and that, and nothing's happened. I haven't screamed at anybody, but all of a sudden I start noticing my heart's pounding. Yeah.
So even an expectation or a manufactured assumption in your brain leads to this response, or can lead to this response, even if nothing actually was a trigger. It was just your expectation created this trigger. So that leads us nicely into the FSM conversation. Remember at the beginning of this, if you're still hanging around here, we talked about the footprint, right? So we talk about these things happening on a tissue level and on a system level. So if we can kind of pair the first part of this discussion with the last part of this discussion, FSM is one way to manage the pain and treat pain by helping to reset some of those tissues and cells and systems. So what we can't say with FSM is that we treat, interstitial cystitis, and I can't as a physical therapist. But what we do use FSM for is to treat pain and inflammation. It's categorized under a TENS unit. So one of the
talk about what FSM is. So it's categorized as a TENS unit, but it's not a TENS unit.
So it is classified as a TENS unit, but it's more than. We need to say it's more than just a TENS unit. Okay. So one of the unique things about it is. The hypothesis is, if you've read works like The Resonance Effect or The Electric Body, the hypothesis is there are certain frequencies in our bodies and in our tissues and in our world as well that resonate and vibrate at a predictable frequency. So what we're able to do hypothetically is target on the cellular and the tissue and the symptom kind of level, instead of just going, oh, cool, we'll crack your neck, we'll make your neck feel better. Or, oh, cool, I can put some needles in that and I can start to move this chi here or there. We can actually proposedly treat the pain and specifically identify which tissues it might be coming from. So for instance, that's why it's called frequency specific. We're able to modulate these frequencies to tune them in very frequently, or very specifically, to the tissues and to the structures that are painful and inflamed and otherwise dysfunctional. What Carol McMakin has shown in her research is a statistically significant measurable change specifically in inflammation markers, interleukin factors, substance P, to name a couple. Tumor necrosis factor is another one. So the way that we can bring that kind of a specific treatment into your patient population and our patient population is we have the ability to go, interesting, I can kind of scan through some of these numbers and see which ones give us the positive effect. Is it muscle tissue we need to treat? Is it connective tissue we need to treat? We're allowed to treat pain. We're allowed to treat inflammation. How do I select the right muscles? So one of the or I should say, how do we select the correct tissues, target tissues? Yeah. So the unique thing about interstitial cystitis, and you and I have had a nice conversation about, it's not always IC. Sometimes they've renamed it to, what do you call it? Insidious bladder pain or bladder pain syndrome, or BPS, right? Bladder pain syndrome?
Yeah.
Tissues, target tissue. Yeah. So for you, the approach that I took, since I can't treat the urogenital system, I went back to the autonomic nervous system and the spinal nerves that feed information to pelvic floor muscles, abdominal muscles, and those abdominal structures, bladder and otherwise. So I'm not treating those structures, I'm treating the nerves, which I'm allowed to treat, that are communicating with those structures. Definitely. So many of the pelvic, not many, as far as I know, as far as my knowledge, all pelvic floor muscles are innervated by spinal nerve roots from T10 to about L2 or 3. And then you pick it up in the sacrum as well. So that's what we did for you, was we put the frequencies, we targeted them over your thoracic spine and over your abdomen. And we just walked our way through some of these nerve structures, some of these muscle structures, to treat the neurogenic component of your condition. The pain, the incontinence, the stream, whatever, all these patients, however they present. And that was the stuff we measured as far as, how do we know we were making a meaningful change? We talked about all those details. Do you have pain during this? Do you have pain during that? Are you able to, frequency of urination during the day, at night, whatever. And we can measure that as subjectively. We can kind of track that over time. So lead me through the next of what we need to clarify when it comes to.
Yeah, I think people just want to know, I think the question is with FSM, where is it available? How does it work? I knew, upregulating the mitochondria was one of the things that I found very interesting. And like, where do you put it on your body? Like, just explain the process.
Yeah, so I talked about those footprints and how we needed to make that make sense. So the frequencies are able to theoretically address the cellular level so that even though the infection's gone, even though the toxic waste and whatever other metabolites are gone, if there's still this footprint that has this cell kicked into that reproductive cycle that's wrong or not what we want, the FSM is specifically able to target and kind of kick that back to the reset. What's cool about that is when we measure the sympathetics, we can't ever push adversely into the quote unquote wrong direction. It almost always, as far as the research goes, it lands in the normal ranges. So we kind of kick and reset the tissues.
Because that would be a concern I would have too. Be like, wait, can you take it the other way? Yeah.
I mean, okay, that goes back to the conversation.
Modulator then.
What's that?
It modulates it.
It modulates it, and reset's a nice word. There are patients who get worse, but then the question is kind of like the pelvic floor case that we described earlier. Are we treating the right thing, or are we just chasing the symptoms, right? So we got to kind of figure out, did the FSM make you worse, or was it the fact that we treated certain things that were, once we reset them, they were actually contributing to, whatever else was going on in the system.
Well, you remember Andrea said the IC setting made her worse.
Right. Yeah. And there are a lot of patients who are like, oh my goodness, this is so much worse afterward, whatever the condition might be. And then, and actually even whatever intervention, sometimes it's not even the FSM. It's just a lot of, even the nutritional supplements, you're like, oh my gosh, it's worse. And it just takes more questions from the practitioner. What is worse? Like maybe we just undid a couple of these things that were holding you together. And so now we actually know these are some more of the problems.
So it takes a lot of patient communication, getting to know them. You have to really understand, listen to them, which is what you've been doing. Also visiting or frequently initially, just because it took us a few sessions for you to get, okay, we got it. This is it. You know? So can you explain, because I know we have 5 more minutes left. Can you explain to the listeners how it actually works? Like there's electrodes, where is it going on your body? Because they probably want to know what it looks like. Sure.
So there's a machine that you can adjust the numbers for the frequency, and it comes out with a handful of cables. So there are 4 cables. You have 2 channels of both a positive and negative. So what we need is to have on one channel the symptoms that we're treating, whatever the condition is, and the other channel is the targeted structure. And then what we'll do is have one of those leads at the top, like the positives at the top and the negatives at the bottom, so to speak. So we're getting those frequencies to cross and move between those channels. So what you'll see is what I use in practice is a series of just saturated towels, because the frequency current, the current is so low that you can use water as a conductant. It doesn't actually shock you like if you jumped in a pool with with electricity in it. You don't get a zing and a shock. It's not dangerous. In fact, we've used electrodes in tubs or pools or jacuzzis for patients. So you'll have one towel, like for this case, along the spine, and the other towel will be along the abdomen. And then the positive electrodes go on the back of the spine, and the negative electrodes go on the front. And then it's really, you don't necessarily feel the electricity going through. Some patients will feel like a warm, soothing kind of feeling sometimes, or they may feel a little lightheaded and stuff. Each patient, each client responds differently. I personally, when I'm treated, I can feel some of the symptoms changing, but I don't get that like dwarfed out, super high kind of lightheaded sensation. I just don't respond that way. Yeah.
It was interesting.
Yeah. So the treatments will last. And some of the frequencies, it just depends on what we're treating. dependent. So you'll need several minutes on the certain pair of frequencies. But really, like what I've created for Mandy is a Mandy specific protocol where we know we move through 2 minutes on each of these frequencies pairs. And we've been able to reset, and arguably the hypothesis is we've reset some of that cellular function back to normal instead of being reproduced, because she doesn't have infections, she doesn't have toxins still. But that cellular memory is like
10 years. 10 years.
Yeah, that's right.
Reprogram the 10 years. Yeah.
Yeah.
Well, listen, I want to know how they can, why don't you tell us before we go, how people can reach you who are listening. What's the best way to reach you now? I know we're talking about making Clint available some with my patients as well. Somehow, maybe renting out stuff. We don't know what that's going to look like. To be honest, we don't know what that's going to look like right now. But it is possible to help people who don't have access. Because the one thing I'll tell you about FSM is you're not going to find people locally. It's hard to find. I've started looking for people for some of my patients, and I can't find people within an hour proximity that does this. So it's not a lot of people have the access to this. So what do you recommend for them?
Well, number one, I don't mind. You can reach out to me directly. I'll give you my email to put it in the notes or whatever. But I mean, it's clintSerafi@gmail.com. So CLINTSERAFI. I'm happy to reach out and just kind of collaborate. If you go on to frequencyspecific.com, that's the group that I'm trained through. It's Dr. Carol McMakin's group. And there is a directory there. But just recognize not every FSM practitioner is on the directory. And also, it's still kind of gaining traction. They've gained a ton of traction even in the last 20 years that Carol's been teaching. But I mean, it's not mainstream like going to a CrossFit box or going to an acupuncturist or going to a massage, right? Like it's still, the reason why we're talking about this is because it's still not well known. And I'm happy to work with whomever to try to figure out how to get resources. The other thing that's a limiting factor is FSM is nice, but it requires that the patients have access to a machine. So one of the things that Mandy and I have talked about is, how do we have a group of machines that we can maybe lease out or loan out or subscribe out. So there are some of those kind of conversations in the works. It's just a matter of finding the solution that works best. Also, because I can't just, I tend to, for all of my patients, FSM or not, create a patient-specific plan. So not every patient gets treated the same way, whether we're using FSM, whether it's IC, or whether it's headaches or anything else. It always is a practitioner specific kind of decision. I want my patients, I want to have that interaction with the patients to make it, to curate it and tailor it for you. So happy to work with you all to make that happen.
Yeah, no, that's good. Thank you for that. And we'll definitely be in touch with the group here when we find out more about how that's going to look. Because I do think it's going to be a very useful tool for people with the missing piece. I think it's the missing piece because I've got like this whole everything covered except for that one thing. So I can get them and do the nutrition and the supplements and the infections protocol, and then we've just got this one thing left. So I appreciate that. So I'm going to let you go because I know you have to go. You have your contractor coming in, and thank you so much for your time. And I put his email in the notes, so go ahead and feel free to reach him out. Thanks so much for everything.
Thank you so much, you guys.
Okay, take care. Bye-bye.
Bye.